So we are going to have excellent mock test. Those who are not joining today, they will definitely miss this tremendous mock test, but we will enjoy this. And I want to make this sessions very much interactive as usual. Every time we are doing the interaction. So I want and I wish you all participate when we are asking the questions. So it's a learning platform. Don't hesitate whether it is right or wrong, but try to understand the basics how to crack the MCQs. So let's begin with this is medical MCQ for all. For those new, we provide study material for all the exams, Middle East countries, especially PROMETRIC 1000 MCQ book, hard copy, and ebook as well. And we also provide the online subscription, live classes, Oman Viva coaching, data flow services, and especially for those who are for second and third trial, we are also providing one excellent short package for them as well, right? We do have also our mobile applications as well. So those who did not downloaded it, I request and urge you download the mobile application. It is excellent application, so you can surf all the website from your mobile phone as well. Uh, and I myself, Dr. Munjal, hemato-oncologist and transplant fellow, almost practicing for 20 years and in coaching for more than 10 years. This is Dr. Arti, who's a consultant pediatrician, Dr. Medi, internal medicine, Dr. Ankit, Dr. Shikha, Dr. Deepali, this is all our team. So we'll go bit in detail later on just to save the time. Contact details. We have a recently published our 1000 MCQ book as well with the questions, answers, explanation, and many pictures as well. Those who are interested, they can go for the hard copy book as well. Right now, I'm in Dubai. If someone needs in Dubai, they can get at some concessional rate as well from Anjali. And coaching, as we had many offers of coachings as well, so you can join with lots of promotional codes. Data flow services is done from here only by Dr. Anjali Sawant. He is in Dubai based permanently, so any data flow documentation, license transfer, registrations, exam booking, you can contact her. And the big part is that we recently, means yesterday, we launched the Emory residency program as well. So thank you very much all for your kind support, and we had an excellent number of students. They attended the Emory mock test. Sorry, Emory residency. This get together and launch program as well. So that's the great. Yeah. So let's move to our main subject today, mock test. Read the questions well and try to post your answer, right? A question first in front of your screen. A 46 years old man with past medical history of HIV, not on any retroviral therapy, present with fever, headache, and impaired mental status or impaired mentation. On examination, he has a weak meningeal signs. LP is performed with very high opening pressure. CSF lab shows monocytic predominance and positive cryptococcal antigen testing. What is the most appropriate management for this patient? Options are IV amphotericin B plus flucytosine for 2 weeks, followed by per oral fluconazole, ampicillin with amikacin, steroid, none of the above. So your time starts now. You post your answer in the chat box. Great. Sorry, is audible now, Dr. Sharma and Dr. Naresh?
Yeah, audible, sir.
Yes. So, any comment, doctor? So, what's the
Yeah,
diagnosis of this patient? Yeah, yeah, we discussed. Go ahead. What's the diagnosis
I
of this
think
patient?
I think it's a cryptococcal meningitis infection, and because patient already has HIV, patient and all haven't taken the treatment of HIV on ARD. So
Right.
and
Great. So, primarily the diagnosis is HIV, right? He is right,
and
not on any medication. So, probably he's I mean the CD30, I mean CD4, CD8 count would be also hopefully the low. Patient has now fever, headache, neurological, and weak meningeal signs, and they are saying positive cryptococcal test, right? So this is a HIV positive immunocompromised with cryptococcal meningitis. So one thing you have done, right? Investigation we have also done, right? We did find out this cryptococcal antigen, right, in the CSF, cerebrospinal fluid, by doing the LP. So what's the treatment now, right? So what's the treatment now? What do you think? What could be the treatment for this patient? Right. So here the answer is IV amphotericin B
IV
with
amphotericin being
flu,
done.
yeah, flucytosine for 2 weeks, followed by oral fluconazole. Right. Ampicillin and amikacin is mainly for the bacterial meningitis, and when there is a raised intracranial tensions or signs of raised ICT, you should add the steroid in top of the antibiotic or antifungal or antiviral. So you need to know now the meningitis. So meningitis, right? So this is absolutely high yield questions. If you don't know, you write down what they can ask you in the exam. So I'm trying to make a many question in one question. So one, you should know what is a bacterial, what is viral, and what is a fungal meningitis. This is your homework. How you differentiate one from another. Second thing, and right, and how the CSF picture. Sometimes they ask picture of CSF. What is a WBC in the CSF? Neutrophil or lymphocyte, right? What is a, if it is a lymphocyte, 90% lymphocyte in CSF, what is the differential diagnosis? How you can see the tuberculous meningitis picture? These are the few standard questions they are asking for years and years. So nothing new they will ask you in the exam, believe me. But our concepts are not good. That is why we are making some few silly mistakes, right? So you need to know along with this, and HIV is again a very important part, right? So we'll cover probably next time HIV in bit detail as well. But HIV, what they ask, how you diagnose the HIV, what is the treatment of HIV, and basic treatment with some side effect possible HIV drug. They are asking very frequently. So this is a cryptococcal meningitis. LP means lumbar puncture with standard workup with a fungal culture, CSF, India link stain, and or cryptococcal antigen testing is the most sensitive, which we did it and it is positive. And management is IV amphotericin B. Amphotericin B is an antifungal drug, and the toxicity of amphotericin B is nephrotoxicity. So you must monitor the renal function test while someone is on amphotericin B, and flucytosine for the 2 weeks, followed by the PO fluconazole, means oral fluconazole. And how long you continue? continue until the CD4 is more than 100 for at least 1 year. So it should be a long treatment. It should be continuous. So first 2 weeks it's a IV, and then you switch on the oral, right? So this is what the thing is, and complication, as you know, right, in high intracranial pressure, high opening pressure might require serial LPs, right, or VP shunt, ventriculoperitoneal shunt, and you should start the antiretroviral therapy as well, because patient may sometimes get opportunistic infection, especially the CD4 8 counts are less than 100, right? So this is the thing. So you should know how to treat the cryptococcal meningitis. This is very, very important. So you can also check your score. I mean, what's you posted the answer and what's the real answer. So you get the better idea. Let's switch to the next question. 55-year-old female with past medical history of type 2 diabetes mellitus present with a chronic red rash over the cheek exacerbated by alcohol and spicy foods. Exam shows a central facial erythema with associated telangiectasia. This is the picture in front of your screen. This looks like, so how you gonna treat this patient, right? So is it a laser therapy, retinoic acid, erythromycin, topical ointment, doxycycline? What's the diagnosis? So as I told you, every time what we are discussing is the triad. So you start with the triad. So first of all, your main job is the diagnosis, and what is they are asking here, after the diagnosis, right, I would like to treat this patient as well. So I need to have two answer in one question. What's the diagnosis? So anybody is interacting, give the diagnosis and treatment. Anyway, they are asking for the treatment. What is the treatment of choice? So without diagnosis of this condition, how you gonna treat this patient? So first make a diagnosis. Yes, anyone wants to try this?
Is it SLE?
SLE. So how this is doesn't looks like a butterfly ration. So at what point favoring the, I mean, and is SLE is exacerbated by alcohol and spicy food? Yes or
Doctor,
no?
I think so. It's telangiectasia.
Great, wonderful. It's Rosacea. Yes, that's correct. That's the answer. So Rosacea is the answer. This is a classical picture. What is the difference between this and that? Right? So difference between this and earlier is that there is a I mean, butterfly rash is classical for SLE. So on the face, what how you exactly see on the face in butterfly rash is like malar flash or bull maxillary, right? Butterfly rash on the both the side usually you see, right? So this is the telangiectasia, and telangiectasia is not there in the things, and it is not I mean, SLE rash is not exaggerated by alcohol or spicy food, right? So this is a rosacea, right? Do you know or anyone know what are the different types of rosacea that is also asked in the exam? Murad, what's the treatment now? So you make a diagnosis that this patient has a rosacea. What do you think? What how you gonna treat this patient? Or is there any type of the rosacea? Is there any type of the rosacea? Is
If
there any
it's a
various?
telangiectasia, we will do sclerotherapy.
Okay. So, is there any various types of the rosacea? So, rosacea, there are various types. So, our diagnosis is rosacea, right? There are four different types, three, four main different types. Papulopustular, another is erythematotelangiectic. This is what this patient has, right? Telangiectasia and erythema. So, this is erythema and telangiectasia, right? Another is a thymatus and another is a ocular. So these are the various types of rosacea, and here the erythematotelangiectasia treatment is a laser or pulsed light therapy. So this is the treatment, laser or pulsed light therapy. So answer for this question, right, is a laser, right? So this is the treatment. Various type, say for example, papulopustular type of rosacea, right? There is a papule and pustule formation on the face, right? Topical metronidazole, because
Yeah.
most of them in the pus they contains the anaerobic, so metronidazole, then azelaic acid and ivermectin is a first line treatment, and consider the oral doxycycline for the second line. So doxycycline is in the options, but when it is a papulopustular, right, not in the telangiectasia, right? So it's a treatment. And second thing is erythro telangiectasis, as I told you later. Then Pymetas oral isoretinoin, it's a vitamin A derivatives and laser therapy. And ocular, right, there is a treatment with topical or systemic antibiotics. So this patient high yield fat, right? So these are the various multiple types of this, right? These things how they differentiate. This patient is classical erythrotelangiectasis, then papules and pustule on the central face, on that is a papulopustular. Irregular skin thickening, it is a phymatous. And ocular, as I told you, conjunctival hyperemia, eyelid telangiectasia, corneal ulcer. This is how they present with rosacea. So that's it. This is the second answer. Though little tricky questions, but you don't expect in questions. So our brain is trained that, oh, we do the very lollipop questions, one-liner questions. Believe me, nobody will ask you the one-liner question. They will ask you lots of pictures, lots of ECG, lots of sonographies nowadays in exam. So you must have to prepare very well with all various kinds of questions, right? So that is why I included all varieties of questions today, though little tricky, but you should prepare yourself. I don't want anyone to fail in this group, right? But until and unless you prepare well, it's little difficult. Believe me, I don't want to scare you, but this is the fact, right? So prepare well, right? And give the answer well in the mock every time. Third questions, right? So you check your score. 2 out of 2 is very nice score, right? So somebody has zero score, it's not good score. So you check your own score. You don't need to display to me or shown to me that what's your score, but you assess yourself by mock test that where are you standing and how much the more preparation you need to do now onwards. 30-year-old male with no past medical history present with headache, confusion, nausea, vomiting after escaping from a factory fire. On examination, he is hypoxic and has tachycardia with bright red mucous membrane. His hypoxia does not respond to supplemental oxygen. Lab are consistent with an elevated anion gap metabolic acidosis. What is the most appropriate next step in the management? Options: assess and secure airway, breathing and circulation, hydroxycobalamin and sodium thiosulfate, sodium nitrates, all of the above. Once again, come to my triad, what's the diagnosis and then treatment. So by and large, they are asking for the management. So most likely they are interested in the treatment amongst this option. But before that, you need to do the diagnosis. So your time starts now. You think over it for 10-15 seconds and try to post the answer in the chat box. Samsung SM, I don't know what's your name. Dr. Sapna Rani, any comment would you like to make this on this MCQ? Dr. Sapna Rani.
Sir, I think A will be the right answer of this question.
A will be the right answer. Okay, fine. So let's discuss. This is learning platform. Get yourself relaxed. Take your time. Don't get panic and tachycardic. Get relaxed and listen the things so you will understand and learn more. So what do you think? What is the diagnosis first of all? Without my triad, if you do the practice at home, right, it won't help you.
Sir, it is carbon monoxide poisoning, I think.
Carbon monoxide. Okay. So in carbon monoxide, what do you do when there is a carbon monoxide? Though it is not a carbon monoxide poisoning, I'll get back to you with the proper explanation, right? Because carbon monoxide poisoning is usually respond to oxygen supplementation. Here he is saying his hypoxia does not respond to supplemental oxygen. So in carbon monoxide, let's say for this example, this is carbon monoxide poisoning. So how you gonna treat the carbon monoxide poisoning, Sapna Rani? Forget about this MCQ.
Sir,
If you have a patient of carbon monoxide poisoning, how you gonna treat?
Sir, we have to give the oxygen, I think.
Okay, you have to give the oxygen. Fine, fair enough. Right? And after giving the oxygen, they will improve or they will not improve.
I'm not sure, sir.
Fine. So, what's your homework, doctor? Today is to go open up the book, any standard book, here is Oxford or Master the Board Step 2 or 3 or First Aid, whatever you like. All three books are good and recommended. So, stick to the one book and read the
Yes, sir.
book. And everyone, those who doesn't know the management of carbon monoxide poisoning, you must go and read it. You must go and read it. It is a very
Okay, okay,
common
sir. Fine.
things in fire and house fire. And also, this as a young male with no medical history, headache, confusion, nausea, vomiting, escaping from a factory fire. On examination, he has hypoxia, means low oxygen saturation, and tachycardia with bright red mucous membrane. Unfortunately, the hypoxia does not improve to the supplemental oxygen. Labs consistent with the acidosis. So, answer is here the cyanide. SS, this all are the answer. Assess and secure the airway breathing circulation, hydroxycobalamin, sodium nitrate. These all are the treatments. So answer of this is all of the above. Everything will be treated. Complication and what is the high yield fact? High yield fact means how you differentiate one from the other. So contrary to CO, C means carbon and oxide. Carbon O is one. If it is CO2 and carbon dioxide, this is carbon monoxide, right? So this is all biochemistry. So CO, so contrary means opposite to carbon monoxide poisoning. Cyanide poisoning does not respond to supplemental oxygen. And what is the pathognomonic for this? Is a cherry red skin is the only found in patients in minority. But if it is found, it is a pathognomonic. So this patient is pathognomonic patient for us. Two strong points which is not there in the carbon monoxide poisoning. Carbon monoxide respond to the oxygen and supplementation, which it does not. His hypoxia does not respond to supplemental oxygen, means it is not a carbon monoxide. And another is a bright red mucous membrane, which is seen in a very minority of the patients as per the literature, right? And if it is present, it is pathognomonic. What do you mean by pathognomonic? Pathognomonic means having something which almost confirms the diagnosis that, okay, fine, this is the things only, right? Having ST elevation in ECG, it is STEMI, that's it, it's pathognomonic. Or rod presence in the cytoplasm, it's AML. This is pathognomonic. So here the pathognomonic is what? The cherry red skin. So you need to remember any poisoning, either carbon monoxide or cyanide, if you come in the exam, you need to focus yourself in two things, whether it is improving to supplemental oxygen, yes or no, right? And what about the mucous membrane or what about the things, right? If it is a cherry red and not responding, it is not a carbon monoxide. That's it. So your homework again is to not just read the carbon monoxide, this cyanide poisoning as well. It is very frequently asked in the exam. So let's move to the fourth questions, which is very, very important. And lots of doubt will be cleared here for lots of confusing topic in these questions. 15-year-old male undergoing appendectomy develop increasing temperature, acidosis, and muscle rigidity within 20 minutes after administration of succinylcholine. How will you manage this patient? So you are a young boy who is on the table of operation theater planning for appendectomy, and within 20 minutes he has an increased temperature, acidosis, probably the bad breathing, right? After supplementation or after giving the succinylcholine as anesthetic agent, how will you manage this patient? Pause surgery and discontinue the trigger agent, administer IV dantrolene, cooling patient with core temperature of more than, if it is more than 39 point this, all of the above can be correct, or none of the above, that is E option. What is the diagnosis and the treatment? So first of all, you need to make the diagnosis what this patient is suffering from, what went wrong during the succinylcholine administration. You can open up your mic and post your answer. Yes, Radhika, any comment on this? Radhika?
I'm in the OP.
Oh, sorry.
So I'm in the OP.
Okay, carry on. Sorry. Yes, anyone? Siddhant Gangurde. Any comments, sir? What do you do when you have a patient in your OT? You are an operating surgeon, and after 20 minutes, patient develop this. Any clue, Dr. Siddhant? Dr. Utpal, would you like to comment on this?
Sir, hello.
Yes, you are very much audible. Go ahead, sir.
Yes, sir. Sir, I think it is the answer B would be the answer.
B.
Option
That
B
is
would be the answer.
administer IV
Enrolling.
dentrolin. Okay, so
Yes.
before that, can you able to tell me what is the diagnosis? What this condition is called as when
Sir,
you administer succinylcholine to any patient, right? And the patient develop the high grade fever and all blah blah, right? Muscle rigidity. How you explain these patients? What is? I'll give you little clue. Let's tell clue. In exam, you won't give the any clue. In exam, there is no Dr. Munjal who can interpret and dissect the questions for you. You need to do by yourself. So, is it neuroleptic malignant syndrome? Is it malignant hyperthermia? It is serotonin syndrome or something else? Clue for you.
so it's malignant hyperthermia.
It's a malignant hyperthermia.
No, sir.
This is
This is neuroleptic malignant syndrome.
neuroleptic malignant syndrome. So, yes. So, any Siddhant
I
doc.
think I think it's serotonin syndrome.
Okay, so there are three answers in
See,
the house,
serotonin
and
syndrome.
yeah,
Yeah,
so there are three answer
serotonin
in the.
syndrome.
Sorry, let me mute all because somebody is not understanding. Lots of talk behind. So anyway, you can open up your mic, right? Anyone wants to interact? Anyone now? Tell me the answer. We'll discuss. This is very important and it is very confusing as well. So I want to completely clarify confusion amongst these three to you today in next 5 minutes. Yes, anyone? Yes, Siddhant, you were telling Dr. Siddhant that what's your answer? Are you there in the class? Yes. Yeah. Anyone wants to try lastly because we have three answer in the group. So those who become a volunteer, I would like to ask few questions for the clarity of the more than 30 doctors now in the group. So it will completely clarify the concept because we are always confusing between these three syndrome, right? So if anybody wants to start, just tell me. I am not in hurry at all. I am not in hurry at all. Yes, anyone volunteer, any volunteer?
Serotonin syndrome.
Malignant hyperthermia.
Okay, malignant hyperthermia. So what's your name, sir? So I tell you properly. Okay, so now tell me, sir, what is the difference between malignant hyperthermia and neuroleptic malignant syndrome? This is the first questions arise in our mind every time whenever
Malignant
talking about the.
hyperthermia usually anesthetic
Yes,
drug complications. Neuroleptic malignant syndrome, most of the antipsychotic drugs will cause.
excellent. Very excellent. This is excellent point you shared, right? So, neuroleptic malignant syndrome, neuroleptic, right? So, it's an antipsychotic drug or the drug which, right, you use for the depression and all blah blah various things you using. This is this is for the neuroleptic malignant syndrome and malignant hyperthermia is after giving the anesthetic agent, right? Especially the succinylcholine you get this. So this is an excellent schematic presentation. I would like to explain you very nicely. So you never ever make a mistake. So first of all, malignant hyperthermia. So the key point in here is the hyperthermia, right? Which is not usually there in most of the patients. but the extremes of temperature is usual in the malignant hyperthermia. Inhalation of the anesthetic. What is the causative agent or causative agent? It's an inhalation of anesthetic drug, especially succinylcholine. So when you give the succinylcholine to the patient, within few minutes, understand this logic, within few minutes, in the minutes, not in hours, in minutes, right? So this patient is a 20-minute, our patient. Now remember our patient within 20 minutes. So within minutes to hours, usually in first hours. I have seen few patients, one of my patient died as well, the same scenario. So this is not just the scenario, this is my one of my patients as well, right? So within 1 hour he developed the extremes of temperature, and that is a severe hyperthermia, right? And because of that, this patient may develop agitation, mental status is agitated, and bradykinesia. Brady means less, tachy means why. So right, the muscle symptom bradykinesia, right? And what's the treatment if you have such a scenario in your thing, right? So patient is taken for the surgery. Within 20 minutes, he develop the agitated bradykinesia, extremes of fever and neurological things. First of all, hyperthermia. So what is the basic concept? The logic is to cooling and give the muscle relaxant. What is the agent? Dantrolene. So here the answer is all of the above. But I want to make you understand all these things, not just the malignant hyperthermia, how it differs from the neuroleptic malignant syndrome. This is extremely important. So here, as we seen, as Dr. rightly said, right, succinylcholine is the culprit agent, and this is succinylcholine, this culprit agent, it's an anesthetic agent. And now here, no anesthesia, here the neuroleptic antipsychotic drug. So antipsychotic drug, especially the dopamine antagonist or Parkinsonian withdrawal medication, right? So this drug, so antipsychotic drug, so it is a different. This is what is the causative agent? Antipsychotic drug, and what is here? Anesthetic agent, right? So there is a difference. There is a classical history in the exam that somebody taken for anesthesia within half an hour, 1 hour, something developed wrong. Hyperthermia, bradykinesia, patient agitated, patient has neurological disturbance, blah blah. Go for malignant hyperthermia, while neuroleptic malignant syndrome, look for the history. They must give you that patient as a depression, patient in antipsychotic drug, right? So you just need to remember it is never happen within hours. So this is second biggest difference. Here one is a drug difference, here the anesthetic agent, here antipsychotic agent, here the time frame within minutes. Nothing happens in minutes to hours here, days or weeks. So you today started antipsychotic drug. After 3 weeks, 4 week patient present with such symptoms. This is neuroleptic malignant syndrome. They never develop overnight. They never develop in few minutes or hours. Here no minutes, no hours. Here days and weeks, days and weeks. So probably 3 weeks, 4 weeks, 5 weeks. So you must look for the what drug before answering between these two questions. Whenever you have neuroleptic malignant or hyperthermia, first two questions you need to ask: what is the causative agent? What is the time frame? So your answer is done almost in these two steps only. What other muscle this is? It is a catatonic and mute, and there is a hyporeflexia, and here the important is rigidity. Here no rigidity. Rigidity is a bradykinesia, right? So kinetic activity is a low. Here the lead pipe rigidity, like a Parkinson, right? And here the mild hyperthermia. See, this is again a very extremely important. Here the temperature is not high. Here they will say classically in this scenario is 103 Fahrenheit, 104 Fahrenheit, or more than 32, 33, blah blah, like Celsius, right? Here is a mild hyperthermia. It's a mild hyperthermia, right? So it's a different thing. Again, here the cooling is a treatment of choice, right? Cooling, right? If the patient has hypothermia, and here the completely different reversal agent, that is bromocriptine. Bromocriptine. What is a bromocriptine? Can anyone tell me what is a bromocriptine? What is the indication of bromocriptine? Which is the condition where we use the bromocriptine? It's a very important question, high yield question in exam, DHA, MOH. Anyone knows what is the indication of bromocriptine? So here one is a neuroleptic malignant
Stop,
syndrome where
Inhibitor.
we use them.
stop
Where another,
breastfeeding.
sorry,
To stop breastfeeding.
Prolactinemia.
okay, prolactinemia or hyperprolactin, right? So bro, keep the bromocriptine in mind, and go and find out what is the side effect of bromocriptine. That's your homework. right? So this is two. Now let's come to the third. That is also confusing many times in our minds. Then how the serotonin syndrome is differentiated from malignant hyperthermia, neuroleptic malignant syndrome, and serotonin syndrome. So as the name itself suggests that the serotonin syndrome, so something is wrong with the serotonin. So serotogenic agent and drug abuse. So serotogenic agent. So which are the serotogenic agent? Can anyone tell me the serotogenic agent? These all are important. You don't need to mug up the things. You don't need to just solve 25. I'm saying you need to completely 100% utilize your brain. God has given us very nice brain. So serotonin syndrome. So there is a serotogenic agents. So if you don't know, you go and read it. Right? What drug contains serotonin? So serotonergic agent and drug use. It is usually NARS. It is usually NARS, right? Usually in the R. So here, very long history, this is a neuroleptic, right? So this is not even in a minutes, hours. So this is not in a minutes, right? So something is in the minute, it is only one thing, right? So this is little you need to know. They are also confused and agitated, right? And there is a myoclonus more in lower extremities than upper extremity, hyperreflexia. So this is a difference. Hyperreflexia, hyporeflexia, very bradykinesia, right? And initial support cooling is treatment in all, and reversal agent is completely different here. Cyproheptadine and chlorpromazine, right? So this is how you need to know the things. So they may ask you hyperthermia, how they present, what is a causative agent, what's the time frame of presentation, how they present, and what's the treatment. So if you know this chart very well, you can answer any questions related with this. So I try to compile it for you guys just to make it more clear. And until and unless you have something like this, right, whenever you have any confusion in any disease, two disease, you try and find out what is the difference between one and two. I think this is how I do in my practice, right? So if I don't know how to differentiate acute leukemia from chronic leukemia, right? So I'll go and read it and I'll try to make it acute leukemia, chronic leukemia. What involved, what time frame, how they present, what's the investigation, what's the treatment. Complete clarity in your mind. So whenever you have problem with the two, three diseases, right, try to figure out in this way. So that makes you better, right? So that's it. So I think it's pretty much clear from my side. I'm pretty much clear to you guys to explain this all three: malignant hyperthermia, neuroleptic malignant syndrome, and serotonin. This topic is definitely, this is tricky and all the time confusing, but now I think it's bit better for you, right? After explanation, so once again you can revise it. So next questions in front of your screen. A 30-year-old pregnant female present with 1 month of presents with 1+ month of appetite for the appetite for an ingestion of non-nutritive substance. 30 years old pregnant female present with more than 1 month history of appetite, right? For what? Appetite for an ingestion of non-nutritive substance like hair, ice, clay, paint. This is how she presents. So, what is the best treatment which helps her, right, to get out of this, right? So she has all the time wish to eat hair or ice, which is non-nutrient things, right? So that is how it is mentioned. So again, just come to the uh, basic things, right? So how, what is the diagnosis of this patient, right? So first you need to make some diagnosis, then treatment,
Pica,
right?
iron deficiency anemia.
Like this is iron deficiency anemia. Okay. So what this patient is, so this is pica is a what kind of problem? It is a physical problem or psychological problem or what problem it is?
Psychological.
Psychological. So do you think that giving iron deficiency or sorry, iron supplementation will help in the psychological these things? After giving the iron, see if we give the iron supplement as a,
Yes,
say for example to this patient, do you think she will stop the habit of eating this hair, ice, clay paints?
yes,
No,
yes.
No.
Yes or no? You can
Yes,
give
sir.
your opinion. That's
No.
fine.
Yes, sir.
Okay, so half is yes, half is no. I don't know exactly. I have a pool as well in my this computer,
It's
right?
normal.
So
This
and
symptoms will go up.
okay, so anyone wants to comment? Let's. I would like to have three, four more comments. Yes, Dr. Sapna Rani, what do you think? What do you think? What is the answer if this question comes in your exam? Yes, Dr. Kanika, would you like to comment on this, Kanika? Are you listening me?
So
Are you in the
actually
class?
this Pica. Yes, sir. Yes, sir.
O-
Yes,
Okay,
sir.
great. So Pica is the diagnosis. That's fine, right? So now how you manage the patients of
Yes, sir.
Pica? It's a very important question, isn't it? Yes. So how you manage? You have a five
So, sir,
options in
iron
this.
supplement. Yes, sir.
Yeah, go ahead
So I
with
have
your explanation.
an iron supplementation. Iron supplementation will help in recovering whatever because since the patient is having iron deficiency, so it will help recover that symptoms. So that's how these symptoms will be reducing when we recover that deficiency. So physiologically, it will help the supplementation.
Mhm. So what's your answer there?
D, sir, D.
D. Okay. But now if you
Yes.
read the questions once again, doctor, they mention which treatment helps the best to her. So do you think the iron supplementation is the best to her? Iron deficiency is one of the manifestation, isn't it?
Yes, sir.
Nutritional things, right? So say for example, you supplemented the iron and patient again keep eating this for more time. Then what will you do? What is the best for her? Just for discussion purpose. You are thinking it's pica, it's okay, fine. This is the confirmed diagnosis pica. You supplemented iron, but patient did not stop this habit. What will you do? Patient continue. You supplemented the iron
Yes, sir.
properly. You had given the standard dose
Yes,
to
sir.
the patient. You counseled the well, but still patient is eating. Then what you do? What's your next step?
So, sir, this is one of the sign of if we see in patient who are going through some kind of depression, so
Okay,
it is seen in these patients as well. So, we treat the
wonderful.
patient with SSRI, sir.
Excellent. That is what I want to hear from you. So SSRI, right? So this is the something which helps the best to the patient, right? Because this is not a psychological problem. This is literature. I'm whatever I'm posting the slide, it is from the standard books, sir. I do a lot of exercise for you. It's just listening and interacting, but for me, and I'm sitting all the way out of my country and sincerely doing the efforts on Sunday. So SSRI is the answer. CBC and ferritin will do definitely, and we'll try to correct the iron deficiency as well. Harm reducing strategies, behavioral intervention, nutritional support, and considered SSRI. Right. So SSRI for this patient is utmost most more important along with other iron B12, whatever you want to supplement. But this is the best things which can support the patient. And what they are asking in the questions, Dr. Kanika, is which treatment helps the best to her, right? Which treatment helps the best to her, and best to her is a SSRI. MAO and inhibitor TCA is the second, third line, right? But the best, safest, least side effect is SSRI. So just keep the things in mind. If you don't know much about the pica, you go and read it, open up. These all points are very important and comes in the exam, right? So next questions again very little tricky but very important for the discussion point of view. A 23-year-old female with past medical history of anorexia is admitted for the severe malnutrition but develops gait difficulty, vision changes. She has just begun total parental nutrition. She is confused and unable to provide history. Exam is notable for BMI, body mass index, all right, is 13.6 kilogram per meter square. Resting nystagmus impaired of multiple extraocular muscle and wide based and unsteady gait. On imaging MRI brain obtained the next day shows bilateral mammillary body T2 hyperintensities. What is the best next step in the management of this patient? Take your own time, little tricky. Without diagnosis, difficult to jump on the treatment. So I always stress on the diagnosis. Think over it, what this scenario could be. Take your time. If the questions comes in your DHA paper in front of you, how you gonna react? No one so far, no one. I wish you post the answer with the diagnosis.
Very,
Or
very.
think of some. Sorry,
Maybe very, very. Very, very
it is a
disease.
this is
Vitamin B1 deficiency.
berry disease. Okay, okay. So how many types of berry?
Two
How
types,
many
dry
types of
beriberi and wet beriberi.
dry
Two
berry
types.
and wet berry? Two types. Okay. So what is the difference between dry berry and wet berry? This all are question in exam. So we are absolutely so don't worry about this question. Berry is again a big question. Every time in exam, one question, two questions. So how you differentiate? What is the key differentiating? Like we differentiated the malignant hyperthermia, then neuroleptic malignant, and serotonin. So how you if you don't know, you make a chart. What causes dry beriberi? What causes wet beriberi? What are the clinical features of dry and wet beriberi? How you diagnose? What is the differentiating one from other, and what's the treatment of both the wet and dry beriberi? That's your homework. If you don't know. If you know, you can speak up, so everybody also can learn up. Anyway, so what this is berry. So what points favors now, Doctor Amin? What point favors the berry in this case? How did you thought of the berry? How did you think that this patient has a berry? There must be some clue
The
for me.
MRI report, the,
I
MR,
think
the, the MRI report showing bilateral mammillary bodies,
Okay,
that is one of the
I
fine.
factor.
Okay, that is
I think
somebody's draw.
yeah, I think it's a dry beriberi because the dry beriberi mainly affect the CNS and the wet beriberi mostly affect the cardiovascular system.
Excellent.
I just think so.
That is one of the very
And
It's
nice
a
differentiating point.
yeah.
Right. So how did you get to know about this is a berry? Why it is not a B12 deficiency? Why it is a B1 deficiency? Or what makes you to think of this berry? I'm just trying to understand. What are the point favors?
malnutrition. Severe
Malnutrition.
malnutrition.
Severe malnutrition, and that is again a point, and patient is on a total parenteral nutrition now, right?
Yeah,
She
yeah.
just begun, so something bad with the nutritional status, and amongst this various vitamin A, B, C, D, E, K, blah blah, the B, and amongst it she's have a neurological confused things, nystagmus, also muscle problem, also gait problem, so looks like something wrong with the really vitamin this malnutrition and vitamin deficiency. So, what do you think? What is the answer now? So, say for example, we take it granted that okay, this is berry or this vitamin B deficiency in general. So, what do you want to select from the options from A, B, C,
High
D,
dose
E?
thiamine, high dose IV thiamine.
It
A
will
A.
be
high dose
first option.
IV timing.
Wonderful. So, everybody is correct. Brilliant. So, this is like looks like a Wernicke encephalopathy, high dose IV or IM vitamin B1. Wernicke's
Yeah.
is what Wernicke's encephalopathy is a most commonly associated with chronic alcoholism, but it is also seen in individual with the chronic malnutrition. So Wernicke's is not only just the alcoholism, but it is also seen with the chronic malnutrition. Like this patient is totally on parenteral nutrition, in right, and this chronic malnutrition and includes the anorexia, prolonged starvation, hyperemesis in pregnancy, and malabsorptive blah blah. Okay, fine. So this is basically high dose IV thiamine, right? So can anyone volunteer can tell me the all deficiency of vitamin B? B1 deficiency, what? B2 deficiency, what? B3 deficiency, what? B6 deficiency, what? And B9 and B12. So if you don't know, go and read it, right? What first you need to know the name as well, right? So B1 is a thiamine, right? B1, the name of B1 is thiamine. What is the name of B2? What is the main name of B3? What is the name of B6? What is the name of B9? And what is the name of B12? If you don't know, go and read it. Every vitamin has a different manifestation. Every vitamin has a different This has a Wernicke's encephalopathy, chronic malnutrition, B2 thiamine, right? Anyone know the name of B2? Anyone knows the name of B2? So it's a not good part. You must know. This is basic. They may ask you.
Riboflavin.
Riboflavin B2.
Riboflavin.
Wonderful, wonderful,
B4 is
wonderful,
niacin.
wonderful. So with
Yeah,
let me check the complete list right away. So you know, B1 is a thiamine, B2 is a riboflavin, as we know, riboflavin. B3 is a niacin. All right.
High
One is
reduction
another
hydrochloride.
one second. One B5 is also there and it is called pentothenic for your knowledge, pentothenic, right? B6 is a pyridoxine. B7, let me tell for B7 as well, is a biotin. B7. B9 is a folic acid, and B12 we are giving every day naropd cyanocobalamin. Am I right or wrong? Yes or no? Yes or no?
Yes.
right, sir. Right,
Right.
sir.
So we forget, na, we don't know the vitamin B complete name. So once again do revise. B1 is a thiamine, right? B2 is a riboflavin, B3 is a niacinic acid, B5 is a pentothenic B5, B6 is a pyridoxine, which we usually give. This is MCQ questions. Patient on INH and patient is on INH rifampicin, antituberculous drug. Patient develop peripheral neuropathy. What you gonna add to this patient? So you start the pyridoxine prophylaxis vitamin B6 to this patient. This is MCQ question in DHA. B7 biotin, B7 is biotin, B9 is a folic acid, what we call. So B12 and folate deficiency means B9 and B12 deficiency. So you must know the name. Thank you very much. We'll move to the next. Am I going well?
Yes.
Wonderful. Wonderful. So our job is not just to know the B1. Our job, we are doctors, we are a qualified doctors, we are a great doctor. So we should know each and every vitamin the way I explained you. So our job is not just to mug up the things. Our job is to understand the things. Next, last few questions, just bear with me for more 15 minutes. 25-year-old man with no palpable, with no notable past medical history, present with high frequency, low amplitude tremor of both hands, rarely the face during the periods of stress, without any other neurological finding. Labs and imagings or MRI or brain or blah blah studies are all unremarkable or not significant or likely normal. What is the treatment? Identify the trigger and its management. It's a beta blocker, it's a primidone, or all of the above can be used in this patient. So first of all, again, let's go for the diagnosis. Without diagnosis, you cannot treat this patient. So anyone interacting, give the diagnosis of this patient. What's the diagnosis? Read it properly. We are not in hurry. So somebody is saying anxiety tremor, Samsung SM. So can you tell me what is this anxiety tremor? What is this anxiety tremor?
After some depression.
Yes. What is this anxiety tremor? Joan?
Anxiety tremor, actually, these neurologic findings are not there, and labs and imaging are unremarkable. And it is clearly mentioned it's during periods of stress. Is that right, sir?
Okay. Yeah, you are going well. I'm happy. Yeah, so how you manage or how you differentiate tremor? Physiological tremor, intentional tremor. How you differentiate? How you differentiate, Anita?
That I don't have any idea, sir. Like
No problem. That's fine.
physiological, this is a physiological tremor, I think.
This is physiological tremor, right? By your experience or by your
Yes,
knowledge.
sir.
Okay, so this physiological
Yes, sir.
tremor, what is the treatment then? If it is a physiological tremor, then what's the treatment of physiological tremor? Okay, you think over it for few seconds. I'll catch the another candidate. We see why I created this platform for years and years. I'm doing this for more than 10 years, right? We are not charging even single penny. Who will invest the time? My hardcore wish is to guide you well. I mean, I want to make you fearless about this exam. How you gonna answer this? Nobody will teach you these tips and tricks so coolly and calmly. And this is not a one mock test I'm doing. I'm sitting in Dubai. Last week I also taken. This week I have also taken. So it's very difficult to manage the logistic out of country, sitting in front of laptop. But I would be glad and I feel happy if you learn something from my lecture. Uh, then I will be happy. Otherwise, not. I mean, it's not just like, I mean, you are passing the time. We are in a sincere business, no? So we need to know what exactly it means and how it needs to be done. Yes, anyone? So what's the things? So if you don't know, Anita, you go and read it once again. And whatever the topics we are discussing here, and you don't know, you open up because this same will come in exam. So don't avoid it. That oh, this is we did it. Now this will not come in exam. Don't think in that way. You will
Yeah,
remember me absolutely in your exam hall. Believe me, this all my word will pop up in your mind
definitely,
when
sir.
you see this,
Definitely.
right? So you try to make a list
Definitely,
that what,
definitely.
yeah, so try to make a list that what's like little not understandable to you. Get back to me, right? So this is a one chart I got it for you guys, right? So physiological tremor, enhanced physiological tremor, essential tremor, Parkinson tremor, and cerebellar tremor. So physiological tremor is usually a postural. It can occur at rest. Specific sign symptoms usually no physiological. It's a physiological. Additional feature anxiety and aggravating factor and causes physiological response. It's a physiological response, right? And this is by and large the same, but enhanced physiological tremor is what? Uh, is a postural again. It is at rest. This is at kinetic at the time of the movement. This is absolutely at rest. So most important point in physiological, the tremor can be at rest, right? Postural and kinetic, hyperthyroid and tachycardia. And hyperthyroid and tachycardia means you respond to the beta blocker or you give the anti-thyroid drug. That's it. Essential tremor is a postural. Essential is a postural and kinetic. Specific signs and symptoms essential no. Response to alcohol. Additional feature cause is no. Parkinsonism can be occur at rest like physiological. So physiological Parkinson both can be at rest. But here no specific sign symptom just at rest. Nothing is there. This patient has a bradykinesia, postural instability, rigidity, cogwheel rigidity, right? And because of Parkinson, they respond to levodopa or syndopa, right? And neurodegeneration causes what? Neurodegeneration. So next question is where is the neurodegeneration? What is involved in the brain in the Parkinson disease? That's your homework. And cerebellar tremor is a postural kinetic ataxia. This is important. Ataxia, right? May plus with other neurological deficit and various causes affected cerebellar pathways. So something that. So this is, I mean, small, sweet, beautiful chart I will share with you. Let's come to the questions. It's a physiological tremor. Identify the trigger like caffeine, anxiety, blah blah, fatigue. Trigger management and treatment of comorbid condition that increases the sympathetic activity. And high yield fact is exaggerated with the increased sympathetic activity. An essential tremor different from the physiological tremor is identify other neurological symptoms which may suggest other pathology. Example is involvement or movement disorder or medication effect. And the first line treatment is a lifestyle modification. Obviously, yes. Second, if severe, can use non-selective beta blocker like propranolol, right? And third is second line treatment is a primedone, right? And high yield fact is high frequency action tremor, usually bilateral in nature, worsening with stress and improving with alcohol. So this is what the literature is. So whenever you study and prepare any topic, you must know the basic things about this. Okay, what this disease is, how it present, how you gonna treat, diagnose, treatment. That's it. So it is not, you don't need to read 6 hours, 8 hours, 10 hours a day. Believe me, by my experience, just read quality 3 hours, quality 4 hours. Try to know. Last couple of questions for the ECG. Let's check your ECG knowledge as well. So I try to compile all various combinations of the questions. So you respond to an emergency call. You are responding to an emergency call at a local grocery store where an elderly female has suddenly collapsed. She was shopping alone. She was alone. So past medical history is not obtainable. You cannot get the what the past history, hypertension, diabetes, any past IHD, blah blah. Because she was alone, she collapsed. Bystander says she started to turn around and suddenly fell straight forward. Worker is doing chest compression, but there is no AED. The full form of AED is automated external defibrillator. Those who don't know what is AED, so I'll show you the AED as well in this scenario. So there is no AED on site. So it's a grocery shop. One lady, elderly lady, collapsed, right? And there is no AED. Somebody started the chest compression, right? You quickly assess. Now you arrived, right? Because you respond to a emergency call. No? Your call, you responded to a emergency call to a grocery stop where this story happens. Some elderly lady gets collapsed. Somebody started the chest compression, and now you arrived. You have a team. You are on ICU wheel. You read the monitor and you see this ECG. What is this? Ventricular tachycardia. In this scenario, it looks like a artifact. Nothing wrong. Ventricular fibrillation, atrial fibrillation, or something else. The first diagnosis and then treatment.
It's ventricular tachycardia.
Who is ventricular tachycardia?
Yes, sir.
What? Somebody is having the volume. First of all, I mute all. Sorry, huh? Now you open up your mic. Those who wants to interact, you open up mic. Yes, ventricular tachycardia. Who? Yeah, tell me. I will not do punishment. Don't worry. No one.
Ventricular tachycardia.
Ventricular tachycardia. So how you recognize? This is Dr. Jagadishan, right?
Yes, sir.
So how you say that this patient has a ventricular tachycardia? I'm saying this is ventricular fibrillation.
I think it's
Sorry.
QRS complex not visible here, that's why.
Sorry.
QRS complex.
Yeah, QRS complex, but this is ventricular tachycardia or ventricular fibrillation. There is confusion. Forget about atrial things, right? So we have to understand. Forget about artifact. Patient is asymptomatic, so it is absolutely not artifact. Somebody gets collapse, it's not artifact. Somebody is conscious, well oriented, and nothing happens, no chest pain, neurologically fine. Then you think of artifact. No, this patient is absolutely now collapsing, about to die. It's not artifact, right? So B and D is gone. Now you decide between A and C.
This is ventricular fibrillation. White bizarre QRS complex.
So the ventricular fibrillation is a very bad and the worst amongst all tachycardia. So if somebody is asking atrial fibrillation, atrial flutter, ventricular tachycardia, ventricular premature contraction, first degree, second degree, third degree heart block, and ventricular fibrillation. Lots of condition I mentioned. Ventricular fibrillation is the worst among any arrhythmia. Worst of the worst is ventricular fibrillation. That means patient is about to die in front of you. I have seen many patients in my practice in last 20 years. Patient came in front of me, chest pain. With before I do anything, I apply monitor or they collapse. No pulse, no BP, no respiration, collapse. Immediate start CPR, call AD, start the applying the AD, right? So this is so what's your homework? So this is a chaotic, very chaotic, irregular rhythm, right? The ventricular tachycardia, at least they have a regular monomorphic. This is like a this is classical, this right? VT, right? So this looks a ventricular fibrillation. You need to know the basic. First of all, you need to know normal ECG. If you don't know, go and practice it. Huh? Dr. Maddie, attend the lecture of Dr. Maddie. She is a quite brilliant she's cardiologist, internal medicine. She is also taking regular lectures, right? Every week she is taking 2, 3 lectures. So YouTube video is also there. YouTube, we have a YouTube channel, Medical MCQ for all those who have not subscribed. Do it. All the videos, what I am doing, the mock test and other tests, all everything is uploaded today only on our channel. So go and get it the YouTube channel, subscribe it. So whatever the notification you get it, and look for the ECG lectures by Dr. Maddie, ECG by Dr. Maddie, right? It is there. If you don't find out, drop me a message. I'll share the link, right? So you see, she has explained all the ECGs very nicely, rate, rhythm, right? First degree, second degree, acute MI, right? And various non-STEMI, STEMI, excellently prepare well. It's a dedicated lecture for ECGs. So you go and read it. So this is a ventricular fibrillation. And can you tell me what is the treatment of ventricular fibrillation? So say this patient comes to you, say for example, now you diagnose that, okay, sir, it looks like ventricular fibrillation. What will you do? What's your first or fastest step for this patient? It's a very important question and it is very high yield for ACLS, BLS as well as people will ask you. Wherever you go for any interview, they will ask this question. If you have one patient collapse in front of you, what will you? They want to save the life. And if you don't know the life saving, they are
CPR.
not happy.
CPR. We
Whether
have to
they ask
start
in exam
CPR.
or not, you will get first CPR. Okay, so first is the CPR. So I'll write down the step. First is CPR. How you start the CPR? Patient, somebody has started the chest compression, right? Worker is doing chest compression. So compression is C, right? So how you start the CPR, how it generates. So earlier it was ABC few years back, but now the American Heart Association AHA changed to CAB. Earlier it was ABC, airway, breathing, circulation. Now compression, airway and breathing. So C comes from last to first, right? So it's not ABC, now it's CAB. So you start with the compression, secure and maintain the airway and look for the breathing, right? So somebody started the high quality CPR. And can anyone know what is the high quality CPR? This is question in exam and very common question in a ACLS, BLS exam, which you need to do after your exam clearance, especially for Middle East. It is mandatory before going to the duty. Anyone knows what is the high quality CPR? So if you don't know, you go and read it, high quality CPR. So, okay, we started the CPR for these patients. What next step you gonna do? You started the CPR. You started compression, you maintain airway, breathing, right? Now you what next you want to do? What makes this rhythm to a normal rhythm? Just starting the CPR, would you think the starting the CPR will make things everything fine?
With CPR,
Defib. Defib we have to
defibrillator.
start.
Wonderful, defibrillation. So that is what I want to hear. So once you do the CPR, you started the CPR defibrillation, right? So have you ever seen the defibrillation? How you gonna do the defibrillation? Right? So this is the defibrillator. See, so this patient is collapsed, say for example, right? There are two pads, right? Just it is very important. I mean, you cannot bypass the things. I don't need you to mug up. So there are two pads. AED, activate the AED. AED, the full form of AED, those who don't know, A for automated E means external, it is not in the body, it is outside the body, external, and D for defibrillator, or shortly called as a defib. Shortly in clinical practice, we call it as the get the defib. That is defibrillator basically. So AED is a kind of machine. You don't need to apply your brain. AED has an excellent brain. First, what the step you need to do? You activate the AED, apply the pads. Where you apply the right upper, we call it as right upper, and left lower. And here is the heart. Heart is like heart. This is the heart. Just for understanding. So when you pass the things, it should go through the heart. So it's like a we call it as a sandwich. Heart is in between. Sandwich. Two pad, right upper, left lower. Right. So you apply, and once you apply, AED will analyze the heart rhythm. Extremely important. You don't need to apply your brain. I told you automated. The word is automated. It is not manual. It is not MED, manual external defibrillator. It is automated external defibrillator. Nothing manual. You don't need to apply your brain. You just what the you need to do immediately, right? You need to apply the pad first time. After applying the pad, the machine will analyze. Machine will analyze. You don't need to analyze. AED analyze the heart rate. AED will tell you, right, whether to shock or not. And then this is fourth button is shock. So if machine cell, it's a shockable rhythm, please shock. This is how it will. And if you want to see, you can go to the YouTube. You see the some how it works. So in 5 minutes you get complete clarity. But this is the step. You apply the pad, let the machine to analyze, and let the machine to tell you whether to shock or not, shockable or not shockable. And there are two rhythms which is absolutely shockable rhythm. Two are the shockable rhythm. That is also exam DHA exam question, which are ventricular fibrillation and pulseless VT. Pulseless VT. So pulseless VT, if the VT with no pulse, and VF is absolutely fatal, right? So pulseless VT, pulseless VF. VF is mostly a pulseless because heart is not pumping. There is no generation of the cardiac output, so there is no pulse, right? So pulseless VT and pulseless VF is absolutely a shockable rhythm, right? So this is how the it works. So we need to understand. I don't need you to mug up, right? So you go and read it once again. So this is the basic with schematic presentation. I will try my level best to tell you. So ventricular fibrillation present with sudden death. The best diagnostic tool is the ECG. You cannot tell any arrhythmia, right, or the cause the loss of the pulse without an ECG. So if I tell you the patient is pulseless, it could be ventricular tachycardia, it could be ventricular fibrillation, it could be a pulseless electrical activity, anything. So ECG is must, and must. So any arrhythmia, ECG is mandatory. And last questions for today, probably couple of things, probably second last. You are called by the laboratory which reports gram positive foci in clusters growing from the blood culture bottle. What is the best next step in the management? You start oxacillin, you start erythromycin, you start vancomycin, you start doxycycline, you consult infectious disease because something grown up in the blood culture. Wait for the sensitivity and specificity for the organism, or it's just contamination. Forget about it. No treatment is required. Probably bottle is very bad, so you may have some contamination. You never know. Respond. Last 5 minutes. Just bear with me. Yes. Would you like to tell anything, Dr. Shiaz? This is very common question. Those who are working in ICU, NICU, PICU, high definition unit, right? This is everyday's problem. Gram positive foci in ICU is a everyday's problem. So how you gonna treat? That's it. This is what they ask. Yes, Anita. Any comment, Dr. Afrin Shah? I'll come to you, Murad. Okay, great. So let's see what other our experts panelists are saying. Dr. Antara, any comment? Dr. Anum, Dr. Anum, any comment? Yes, anybody wants to comment?
It's Staphylococcus aureus, Doctor.
Staphylococcus.
Vancomycin.
Vancomycin. Okay. So everybody see. So most of the people are saying vancomycin, so I will go with the vancomycin. So gram positive, right? Gram positive. You must know what are the gram positive, gram negative. So that is your homework, right? What is gram positive and gram negative, and how you differentiate gram positive from gram negative, right? So anyway, this is a very nice picture. I brought it for you. So this will give you little idea about this organism, gram positive and gram negative. So gram positive, if they are like this, right? Coccus in the cluster and bacillus, right? They are in the chain, right? So this is the name Staphylococcus aureus. It's gram positive, Bacillus anthracus, Streptococcus in the strip, Streptococcus pyogenes, right? Diphtheria, these all are dumbbell shaped diphtheria. So these all are the gram positive. And gram negative is what? Neisseria meningitidis, right? Then Streptobacillus, Treponema pallidum, E. coli, which is usually seen in a E. coli is in a GI tract and urinary tract infection. The commonest organism is E. Treponema pallidum, which cause the syphilis, isn't it? Treponema pallidum, syphilis, VDRL, we do it. Vibrio cholerae, which cause gastroenteritis, and these all are the gram positive. So they what they are saying, what they found gram positive cocci. So they found a gram positive cocci, such kind of cocci they found, right? So gram positive cocci, and most important treatment for the gram positive cocci, wherever it grows, it's a vancomycin. So best empiric treatment for gram positive cocci growing from the blood culture is vancomycin. If there is intolerance or allergic to vancomycin, what are the other which you also should need to know? So not just the vancomycin. If not, then linezolid. If not, then daptomycin. If not, then septarolin. Septarolin. So another homework for you. Septarolin is a which category of drug, right? There are five generation. First
This
generation cephalosporin, second generation cephalosporin, third generation, fourth generation, and now fifth generation. So you need to know at least one drug name.
last
That what
generation.
first, yeah, first generation what, second what, third what, fourth what, fifth what. So you go. I think excellent antibiotic lectures is given in Master the Board, step two. Excellent, very clear cut, very excellent. I love it. Right. So you go and read it. It's very important, right? And which will give you the complete idea about the antibiotic, about the bugs, and about the selection of the antibiotic, right? So this is a anytime and whenever you have a gram positive cocci in a blood culture, empiric means before without coming the culture, because culture will not come in few hours. It takes at
Sir,
least
can you
48
repeat
hours
the name
clinical.
of the, excuse me,
Sorry,
sir.
what you want? Yes, sir.
The antibiotic, you said some reference, no, sir. Which?
Cephalosporin, sir.
No, sir.
You need
You
you
said
need
some reference to get to know about
master the board, USMLE, master the board. The Conard Fisher, MTB, you know, that is master
master.
the board. Master the board, MTB or full form is master the board.
Okay.
The author is Conard Fisher. Conard Fisher. If you don't have that book, I will share it in the group. Don't worry. I have PDF. Right? So you go and read
Thank
it.
you.
Master the board. Right? So here the gram positive cocci first is vancomycin. So there are four drugs. Vancomycin, if it is allergic or hypersensitivity or intolerant, use the linezolid. It is commonly available. Daptomycin is also available, and septarolin is also available. So you need to know the four drugs. They may ask you the patient is sensitive, hypersensitive to vancomycin, where you cannot use, right? Then you should know the second, third, and fourth option. And oxycycline is not drug because it is not covering the MRSA, methicillin resistant Staphylococcus aureus, right? I shown you already the Staphylococcus, right? So gram positive coccus or cocci, right? So commonest is a MRSA. There are two type of staphylococcus. Again, it is given in the master of the board: methicillin sensitive and methicillin resistant. So MSSA, methicillin sensitive Staphylococcus aureus, methicillin resistant Staphylococcus aureus. And MRS is one of the most common methicillin resistance. It is a gram positive cocci, GPC, and the drug of choice is a vancomycin. If not, then second, third, fourth, I told you. That's it. And last questions for the today, then we'll feedback back up. A 24-year-old HIV positive woman present with her 16th week of pregnancy. Her previous child was diagnosed with HIV positive after vaginal delivery. What is the most effective method to decrease the risk of vertical transmission? Avoid avoid the placement of fetal scalp electrode, avoid fetal breastfeeding, antiretroviral therapy, cesarean sections,
Avoid
zidovudine monotherapy.
breastfeeding, sir. Avoid breastfeeding.
Okay, so let's discuss. Let's what other people are saying. If you want to read the questions answer, you can read it. Yes, so one answer is in the group is a breastfeeding. So let's put one options of breastfeeding. Last question, so just bear with me more 5 minutes. Be patient. One answer is a breastfeeding. Any other options for anyone? Dr. Amit saying cesarean section. Some AC doctor is showing cesarean section. Dr. Anita is saying antiretroviral therapy. Dr. Sama is also saying antiretroviral therapy. Dr. Pooja Suraj is saying antiretroviral therapy. So now you discuss amongst you what is what is what. Avoid breastfeeding or start antiretroviral triple therapy or monotherapy with the zidovudine or cesarean section will reduces the vertical transmission, blah blah. So let me tell you the answer is correct, Dr. Pooja and Anita and all. All of the strategies are recommended. Everything is important to prevent. All can prevent the vertical transmission. If you avoid the blood breastfeeding, it reduces the vertical. Vertical means what? From mother to baby is a vertical, right? From mother to baby, from womb to baby is a vertical transmission. So what is the most method to decrease? They are asking patient is HIV positive. Now it doesn't become HIV negative, right? But you want to reduce from mother to baby, right? So best is antiretroviral and that is with the triple anti therapy. So all of the strategy means avoiding the breastfeeding, then cesarean sections, everything is important. But among what is the most important? All of the strategies are recommended, but triple ART, antiretroviral therapy, is indicated for more effective management of HIV in the mother to drive the viral load less than 1,000. Zidovudine monotherapy is less effective than triple therapy in reducing the transmission HIV from fetus to babies from 25 to 8%. So quite a big number. Cesarean sections right before the rupture of membrane, avoidance of breastfeeding, intrapartum invasive procedure also decreases this transmission rate. Combining all of the strategy listed would reduce the transmission rate to 1%. So if you avoid the breastfeeding, you look for the cesarean section, you start the antiretroviral therapy. So it reduced the rate to 1%. 1% is good number. I mean, though still there is a chances of transmission even if you take all the precaution, but by taking more precautions, by taking more vigorous steps, right, you probably avoid the transmission of HIV from mother to baby. And that's all for today. Thank you very much all for your kind attention on the Sunday, and it's time for feedback now. So I want 2 or 3 feedback from the group
Thank you,
quickly,
sir.
those especially attended the class first time. So I want to have what you have learned so far. What is new in your mind that which never clicked earlier and now you feel that this point is good for me. Me means you, student. By applying the which strategy you think that this could be a better preparation now. Any feedback?
Thank you. Thank you very much, Doctor, for brilliant
Thank you.
lecture. We have not any comment really. We cleared everything. Thank you very much.
Wonderful for your feedback, sir.
Thank
I'm
you, sir.
trying my
Thank you.
level
Thank you
best.
so much.
Wonderful.
Thank you so
Anyone
much,
else?
sir. Thank you so much for the wonderful session. Thank you so
Wonderful.
much, sir. Actually, your
You are
efforts are, worth appreciable. Especially you are out of station. Still, you are finding time
no,
for
no.
us to
It's my
explain things.
passion. My passion, dear.
Thank you so
Without
much.
passion, you cannot succeed. It's a passion, right? I have otherwise hundreds of
Thank you, sir.
excuses to not to take the lecture, but I never miss it, and I will not miss
Hope
it.
you're enjoying the stay, sir.
Thank you very much. Yeah, I'm absolutely enjoying now.
Thank you so
I'm
much, sir.
enjoying
Thank
this.
you.
Thank you. Take care. See you next week. Thank you. Bye
Yeah.
bye. Take care.
Thank you,
Go and
sir.
subscribe our YouTube channel. You get lots of excellent like same video of my previous videos as well as current videos. Lot of videos are there. Thank you very much.